John Riggi has spent nearly 30 years as a highly decorated veteran of the FBI, and now serves as Senior Advisor for Cybersecurity and Risk for the American Hospital Association and its more than 5,000 member hospitals. In his role, he serves as a national resource to assist members in defending against cyber attacks and other threats to their organizations. Welcome to Advancing Health, a podcast brought to you by the American Hospital Association. I'm Tom Hedderly with AHA Communications. In this podcast, we have the very unique opportunity to talk to two leading experts in the field of cybersecurity, who are also John's close friends and colleagues from the Cybersecurity and Infrastructure Agency, or CISA. That's an agency operating under the Department of Homeland Security. Dr. Reuven Pasternak, Interim Senior Advisor, and Joshua Corman, Chief Strategist, will discuss a CISA Insights report titled Provide Medical Care is in Critical Condition, Analysis and Stakeholder Decision Support to Minimize Further Harm. This is a groundbreaking qualitative and quantitative analysis which models and measures hospital strain associated with excess deaths, as well as the effect of ransomware and the impact such a strain can have on a hospital and region, further contributing to excess deaths. This report tends to confirm what to many is already intuitive, that ransomware attacks on hospitals may disrupt care delivery, risk patient safety, and are threat-to-life crimes. Now here's John to give the proper introductions.
Hello, everyone. This is John Riggi from the American Hospital Association, your Senior Advisor for Cybersecurity and Risk. Thanks for joining us again for another episode in our continuing Cyber and Risk podcast series, Frontline Perspective. I believe today's discussion is particularly important and perhaps one of the most important podcasts we have done. As we have all unfortunately seen, high-impact ransomware attacks on hospitals have increased dramatically since the onset of the pandemic and have resulted in regional disruptions to healthcare. As I have often said on this podcast, in testimony before the Senate, to the media, to the government, really anybody that'll listen, a ransomware attack on a hospital crosses the line from an economic crime to a threat-to-life crime, and should be responded to and pursued as such by the government. Well, we all intuitively know this. However, the perennial question has always been, can we somehow objectively quantify the harm, the negative patient outcomes, and yes, even the patient deaths, which may occur directly or indirectly as a result of a ransomware attack on a hospital? To help answer that question, I have two distinguished guests with me today, who I am privileged to call colleagues and friends from the Department of Homeland Security, Cybersecurity and Infrastructure Security Agency, Joshua Corman and Dr. Reuven Pasternak. Dr. Pasternak is a physician and healthcare executive who is currently serving as an interim senior advisor to CISA to advise on resiliency, safety, and sustainability in the healthcare sector. He is a former vice dean in the School of Medicine at Johns Hopkins. Dr. Pasternak has worked as a system chief medical officer, a hospital CEO, and health system executive vice president with systems in Ohio, Virginia, and New York, and is consulted on these issues in the U.S. and overseas. In addition to his work at CISA, he serves as an advisor to the Carey School of Business at the Johns Hopkins University, the Essential Hospitals Institute, and the Schools of Public Health and Management at Stony Brook University. Also with me, as I said, is Joshua Corman. Joshua Corman is a founder of IamTheCavalry.org and currently serves as Chief Strategist for the CISA COVID Task Force via the CARES Act Emergency Hiring Authority. He has previously served in Chief Security Officer, Chief Technology Officer, and other senior roles. He co-founded Rugged Software and I Am the Cavalry to encourage new security approaches in response to the world's increasing dependencies on digital infrastructure. He is an adjunct faculty for Carnegie Mellon's Heinz College and was a member of the Congressional Task Force for Healthcare Industry Cybersecurity. So, gentlemen, let's get to the issue at hand. In late September, CISA published a report entitled Provide Medical Care is in Critical Condition, Analysis and Stakeholder Decision Support to minimize further harm. Among other issues, the report examined the impact of COVID-19 to healthcare delivery and also took an analytical approach to provide insight into the effects that ransomware attacks can have on the healthcare system. Josh, let me start with you. Could you tell us, in layman's terms, about the genesis and the intent of the report and which agencies contributed to the report?
Glad to. And it's a difficult report. There's a lot in it. It speaks to different stakeholders. So I'll do my best to have the cliff notes here. So first, part of our massively multidisciplinary task force has done analytical products of qualitative and quantitative work throughout the pandemic against those 55 national critical functions to see if we can provide executive decision support, both to CISA leadership, DHS leadership, HHS, CDC, FEMA, all the folks involved in Operation Warp Speed and its successor, and our ability to try to protect the nation's hospitals during this pandemic. Those products were internal to government, and we would do short bursts. We noticed consistently that Provide Medical Care, the national critical function for providing the healthcare at the hospitals to the patient population, was strained the most, often in unanticipated ways. And we used models about cascading failures 1 week and how quickly people were going from conventional care to contingency care to crisis standards of care with expert help from Reuven. And we started to study around the 1 year mark of the pandemic some pretty troubling stats that weren't getting enough discussion. These involved public data sources from our siblings in the federal government. So CISA's role is we're not your law enforcement, we're not your regulator. We want to help lead the effort defensively to understand, manage, and buy down risk to the nation's critical infrastructure. And we were doing some outstanding work there. The reason we wanted to publish this report is around the time the country hit the sobering milestone of 500,000 lost to COVID, we were tracking through CDC's excellent public data source called excess deaths. Excess deaths are the difference between expected deaths and actual deaths for a given region, condition, and time period. While we were all focused on COVID, in addition to those, there were about 150,000 excess deaths in that observation period through March of 2021. And we studied how are these happening. And so the first piece is we could see strong positive correlation between ICU bed utilization nationwide from HHS public data streams and excess deaths 2, 4, and 6 weeks later from CDC public data streams. So their data enabled our analysis and working with physicians like Reuven and other public health hires we made through the CARES Act. This was stunning because I think everyone knows that the phenomenon exists that the more busy your ICUs are as a trailing indicator and a proxy, the more likely you are to have adverse outcomes and death. But we were able to use hard data science to quantify and size how quickly it accelerated through the first 3 peaks of the pandemic. We then started to shift to some more uncomfortable questions with our cybersecurity mission and asked, while we know that the top 2 contributors to those excess deaths were biological and sociological, like people being afraid to or reluctant to go to the hospital and taking too long, and degraded and delayed care affects patient outcomes and mortality rates. But also when they tried to go, they often couldn't get in depending on how saturated their region or their city was for other surges. So we started to say, can cyber play a role? And I know you and I've talked about this since I met you. We've shared the belief that this is not a victimless crime. It's not merely a privacy crime. It's a threat to life crime. And degraded, delayed care, irrespective of reason, can affect mortality rates for heart attacks, for strokes, for pulmonary issues, where time matters, where minutes or hours matter. We can't be down for days or weeks. So a larger body of work towards the back, which we rendered public through this report, tries to quantify how, using data science, we looked at some of the natural experiments of some of the most pronounced victims of these horrible crimes during a pandemic. And what we found is hospitals in a given state, controlling for other variables, same state, same population, same pandemic conditions, under a 5-month observation period after a pronounced attack, we were able to compare, adjusting for hospital type, hospital size, and time period, that hospitals affected by ransom achieved these dangerous stress zones faster and or stayed there longer. And while we can't directly measure which people perish from cyber disruption, we know that delays affect mortality rates, and now we can measure and quantify how cyber affected delays. And it's sobering, but it's also empowering because through that quantification, we may be able to stop debating if cyber attacks can affect life and patient care, and maybe start leaning into what are we going to do about it. There's other nuggets in there which we can and should dig into, and we should also thank the innovation and adaptation of healthcare workers, because while those 150,000 deaths by March of 2021 were unable to be prevented, but for their creativity and innovation during the pandemic, the numbers may have been much higher. We want to make sure that we make informed decisions about how to reduce strain for these. We just missed the fourth wave, but we're heading into flu season, which may be our most deadly yet. And we want to make sure we've communicated these publicly, both as CISA and through our interagency partnerships.
Thanks, Josh. I mean, you touched on quite a bit there, and you did talk a little bit to us about the methodology and the data used to support the findings in this report. And of course, we strongly agree with you that of the heroics and performed by our healthcare workers in the face of the pandemic and the inability often to have sufficient resources, but they, as I always say, adapted, improvised, and overcame. And not only did they perform heroics, but at great personal risk before there was a vaccine, exposing themselves and their families to COVID-19. That's what makes it so heinous for a foreign cyber adversary to attack a hospital during a pandemic filled with ill and infirm. So, you and I get pretty passionate about that. And of course, I relay those passions to the government and up on the Hill. So let me get, you touched on this a little bit. Let me talk to you more about who the audience is for this report. So is it the government? Is it healthcare leadership, clinicians, patients, policymakers, or all of the above? And Reuven, feel free to chime in as well.
Why don't I kick off and flip to Reuven? There are plural audiences here. We know that many hospitals are doing the best they can and may not be able to take much new action. For our hospital colleagues, many may not realize how damaging and how much more cyber disruption can accelerate these excess deaths in quantifiable ways. So for them, between this fourth and fifth wave, we want to offer our left of boom preventative, free taxpayer funded services to improve cyber hygiene and maybe prevent the preventable. And we have some advice there. The dominant groups we're looking at in some of the data, I hope people read this report carefully, is that among those 150,000 excess deaths, we studied which conditions and which populations it's affecting. And selfishly, there should be interest from the 55 national critical functions and the 16 critical infrastructure sectors, because many of these time-sensitive failures like heart attacks, which can be affected by minutes, or strokes, which can be affected by 1 to 4 hours, or pulmonary and diabetes issues. The largest growing demographic of excess deaths is age 25 to 44-year-olds. These are young, critical infrastructure worker age people. Our ability for the country to function across these other 54 is further hampered by sickness and death with each wave of the pandemic. So we're really targeting a lot of our message at them, which is that they stand the most to lose from additional excess deaths. And through their policies, choices on mask mandates, vaccine mandates, workplace choices, they may also stand to reduce the strain on our poor hospitals as we reach flu season. And then state, local, tribal, territorial leaders play a role here as well. And we want them armed with this information as they make policy choices about doctor and nurses traveling to other states, about maximum capacity. Even this last week or so, we've seen certain state governors give executive orders guiding hospitals on how to do capacity planning. These different nuggets have different decision support for different stakeholders, which makes it a little confusing. We would have written different reports for each of them if we had time, but we knew this was time sensitive. And Reuven's been instrumental in helping us understand the equities for both physicians and executives in healthcare, and may have more to add.
Thanks, Josh. So again, John, I also want to thank you for the opportunity to speak with you and to members of the AHA and friends. So to add to the group that Josh has spoken about, I'm reminded when quality came in about 20 years ago as a focus of discussion, and the road we took to hardwire quality into the mindset of everybody who touched a patient, whether it was directly touching a patient, as in physicians, nurses, and others, to people in the supply chain and throughout the system, and how important it was in the contribution they had to making this a safe environment. We now have that same challenge with regard to cybersecurity. Hospitals and clinical groups are operating increasingly on a digital platform. in our ability to get the right patient into the right place at the right time for the right care, and to get the right information at the right time in the right hands for the right care is dependent on a robust digital platform that is moving us in moments as opposed to hours from before. And so we need to and are looking to be sure that our colleagues are aware of the implications of what happens in a cyber attack that, as you and Josh have said, when that platform is disrupted, care is disrupted. Their ability to provide optimal care is disrupted. Sometimes their ability to provide care at all is disrupted as well, and that has consequences. The other message that we want to get into their hands is that while it seems like a complex issue, and it is in many ways, there are some very simple but important things that we can all do to make this a safer environment and to make sure that we address a large number of the risks that we face. And also that the clinical arena should be working in partnership with hospital operations and management because we have the same concerns and common cause in this.
Thanks, Reuven and Josh. I mean, a lot to think about again for our hospital leadership and our caregivers. So I know we've talked about many findings in the report. Although the report seems to be more heavily policy focused, and I have to state a bit challenging to sift through at times, there are what I believe to be some very significant and perhaps startling to some findings or at least correlations directly related to patient harm as you've been discussing in ransomware attacks. In fact, Josh, I'm going to go right over to page 13 of the report. So page 13, the heading is Additional External Stress Ransomware. So the report states in a very academic, almost clinical form, a very significant finding that seems to have been crafted in a very measured, almost contradictory manner. Let me read the statement to you. The statement is, although there are no deaths directly attributed to hospital cyber attacks, statistical analysis of an affected hospital's relative performance indicates reduced capacity in worsened health outcomes, which can be measured in the time of COVID-19 pandemic in excess deaths. Josh, could you expand upon that statement? And then Reuven, also your thoughts would be welcome as well.
The more important the truth in the analysis, the more carefully and clearly it should be worded. So it's unfortunate if it's difficult to parse this. I think in the fuller body of work, I think I can help. Channeling my Italian heritage and speaking with my hands, which you cannot see through the technology of podcasts and radio. In my left hand, I hold that data analysis we did that showed strong positive correlation with regression across states and national levels, that as ICU bed utilization goes above 75%, excess deaths 2, 4, and 6 weeks later, as measured by the CDC, manifest. And the higher up you go, the faster those excess deaths, the larger the total number of excess deaths from those conditions like heart attack, strokes, diabetes, et cetera. In my left hand, we hold that. And I never told you the inflection points, but you can see them in figure 5, which is fairly stunning. And that's just through March. We've now since updated that in some joint work with CDC on several more months of the pandemic to show that the strong positive correlation holds, and it actually inflects a little steeper at certain points. But those inflection points, just to bookend it, if the nation hit 75% nationwide for ICU bed utilization, often an optimal target, the excess deaths 2 weeks later would be 18,000 Americans. If we exceeded 100%, 2 weeks later, we would have 80,000 excess deaths. So it accelerates quite quickly. And I think physicians and hospitals know it's not good to be in the red. I don't think they knew how dramatically it accelerates in this quantifiable way. But in my left hand, I hold that. What we then looked at was hospital strain in the face of attacks in a state versus other hospitals not attacked by that in that state. With that, what we're trying to be very careful in this wording is, while we can't directly measure the cyber attack, what can be measured, the emphasis word on what you can measure in that sentence when Jeff French, our analytical lead, says it, what can be measured is hospital strain associated with excess deaths. So it's really left and right hand, where armed with that instrument on excess deaths writ large, we were able to see that cyber disruption can accelerate and exacerbate that danger zone. It's important to be super clear in our data analysis. We're not in the hyperbole business. We're not in the fear mongering business. And the harder the truth, the more precisely we need to word it. So I appreciate it can be difficult to read. Maybe we have the benefit of Jeff's emphasis that you can't measure the direct, this attack hit these 5 people or these 50 people. But what you can measure is the overall throughput for that hospital, that county, or that region was measurably affected by that cyber disruption. Because these truths are uncomfortable, there's been a palpable and visceral allergy from many of us that even care about this to ever admit there's going to be a loss of life. We've had several attempts in the past to say this patient died from this attack in this country, and they can be dismissed as anecdote. And if you have statistical proof, maybe they'll say, yeah, but let me know when someone's actually died. And I think what's really important about this research is we now have that empirical, statistical, public health backing for the phenomenon, irrespective of any anecdote.
Thank you, Josh, for that perspective. Clearly, I think another way to summarize this is that there is correlation that cyber attacks may result in excess death, but not direct causation. That was found here. An important study for certain. From a law enforcement and a criminal justice perspective, as I've always said, it's really not necessary to roll the body into court, as I would say, because the risk, everyone understands that if you attack a hospital and disrupt care and cause a delay in the delivery of urgent care, as you've said, during heart attacks and strokes, the risk is present of physical harm to the patient. Under criminal law, that is sufficient to pursue the crime, to pursue the attack as a crime of violence or of a potential violence. So it's interesting. I'm not, sometimes when I'm not sure, are we trying to convince other healthcare policymakers? I think the FBI and DOJ get it, but it's really, and for the community to really understand the gravity of what we're saying here. Reuven, your perspective on this, and then Reuven, I'm going to follow up with you for another question on findings on this page.
Sure. To the point of when the case was first made, we wanted to be careful not to overstate the results because we wanted to present what we had that was statistically valid in associations and move on from that solid platform. I will say that in the time since the analysis has been done and the results reviewed, there is more and more evidence coming out from clinical studies demonstrating the impact of stress on hospital systems, including decrease in life expectancy in the United States and 28 other countries, which has been significant. I believe here 2 years, both within COVID-related disease and non-COVID-related disease. So the background of the impact of stress is there. When we get down to looking at the extent to which cyber issues compound that, because remember at the same time that we have cyber attacks, we still have attacks of nature, weather from various areas, as well as other threats. So these are compounding elements on top. And when you hear of a cyber disruption and phrases come out such as ambulances are being diverted, this unit is closed, that is a red card sound to somebody who's in the trenches, because that means that a resource that is normally available to somebody and is critical for people with specific conditions has now been compromised. And maybe that availability is just down the road, or maybe it's 2 hours away. So we do know that when that situation is encountered, and that is becoming increasingly commonplace in many of these, that patients are placed at risk. So we do want to be able to quantify it, but we also know that that does pose a real risk based on our real experience, and that this is also coming at a time when we face challenges and stresses with staffing in hospitals and other internal stresses as well. So we want to be sure that we are considering all of these in terms of the stresses that we're facing in doing this. The last comment I'll make about this is, as we have shared this information with frontline providers, none of them have been surprised at the finding. They intuitively have felt that this was something they would have expected to hear. They didn't know the extent to which it existed, and they were pleased that there was finally more attention to trying to put some scientific parameters around it to help the discussion as well.
Reuven, totally agree with your statement, especially that last part of the statement where you talk about people in the field, the healthcare providers, and those of us that deal with cybersecurity. A lot of this is intuitive. We understand how disruptive a ransomware attack can be to healthcare delivery, and the risk of physical harm to patients caused by a delay in treatment and or the unavailability of medical technology. So you touched a little bit upon some of the disruption caused by ransomware attacks, but there's others. And I'm wondering if you could describe some of the other findings you had there on page 13. What are some of the other types of disruptions that interfere with patient care and possibly risk patient safety?
Well, those risks include the full array of hospital operations and clinical operations. So the ability of hospitals to ensure that they are able to manage the resources they have to be able to get patients into the right place at the right time for the right staff becomes compromised. For people who are providing the hands-on care, the type of care that we have to offer that gets optimal outcomes right now depends on a more complex series of real-time data that changes from moment to moment in some cases, and the ability to have that information available to be able to analyze it and then to execute orders sometimes to people who are distant from your actual physical location becomes fundamentally compromised and compromises the ability to provide care to those patients. In addition to that, much of the care that is provided now starts in the field. So patients with acute cardiac conditions, patients with stroke and other conditions literally have their care starting the moment they get into the ambulance or other transport vehicle. And if that becomes disconnected from the hospital, from the home base, you have already started out behind in terms of your ability to provide state-of-the-art care that makes a difference to the survival and morbidity of those patients. And that's not even getting yet into the operational issues of the hospital being able to maintain flow of supplies and administrative functions as well, which is no small consideration itself.
That we have seen that, unfortunately, in many victim healthcare providers, victims of ransomware attacks, where the loss of telemetry becomes a critical issue, whether it's from the patient room, from the medical device to the nurse's station, even home care. But as you've pointed out, even from the ambulance back into the hospital, folks have to go to paper record keeping for weeks. Most organizations don't plan for that. And again, some of the other disruption we've seen dealing with some of the victims, radiology is down, labs down, even COVID-19 tests, and the inability to deliver cancer treatment is delayed. So huge impact, huge impact. Reuven, if I can come back to you for a moment, also staying on page 13. The last line of the paragraph on page 13, which describes some of the clinical disruptions, which we just kind of spoke about, which result from the ransomware attack, states, and I think this is a master craft of policy here. The sentence is, although there are no deaths directly attributed to the cyber attack, statistical analysis of its relative performance indicates reduced capacity. So, although no deaths directly attributed to the cyber attack, second half of the sentence that responds to that phrase, speaking of relative performance and reduced capacity, could you elaborate on the intent and meaning of this sentence for us in layman's terms?
Sure. So we were being very conservative in making our statement in terms of, can we say that for this specific patient, this is the component that cyber contributed to their altered outcome, or what percentage of the change in survival is attributed specifically to the cyber incident? Absent the ability to specifically present that, we made that general statement, which was to say that when you look at the overall performance of the entity or the system, or even nationally, but let's focus on the entity, system, or region, that when a cyber incident occurs, there is an associated change in terms of mortality and morbidity. That association creates an inference which says that that disruption on top of everything else to the operation carries with it the risk of morbidity and mortality. Additional studies will need to be done and will be done, and some are underway to look at the extent that we can further quantify that. But I think that was as strong a statement as we felt that we could make now, knowing that additional evidence will reinforce that in an even more solid fashion. Does that help?
It does, Reuven, and thank you and to CISA for pursuing additional studies so we can have further clarity and further define correlation versus causation. I think As you mentioned earlier, that will have significant policy impact across the government, not only for HHS and CISA, but also for enforcement as well, for law enforcement and even in the intelligence community as we pursue these attackers as a national security threat. Reuven and Josh, as we wrap up this discussion, I'd like to briefly give each of you an opportunity to address this last question. Whether you are a hospital CEO, chief medical officer, or chief information security officer, what would you like them to take away from this report and discussion? And most importantly, what would you like them to do with that information? Josh, why don't we start with you?
Yeah, that's a hard question. In the risk management profession for which we participate, we're loath to give flippant advice without understanding all the competing equities, and we know incredibly hard decisions are being made. We felt it was our responsibility to share these models, both qualitative and now quantitative, with hard data science to understand the phenomenon and the system dynamics and the degree to which these things compete with other equities. We hope this informs decisions about travelers for healthcare workers, about the ability or desire or appetite to schedule elective surgeries, which may clog this. We want to encourage early vigilance on when hospitals or regions are approaching these dangerous strain levels that were poorly understood. And we want to offer our assistance to make sure you're as resilient against cyber attacks as possible on the defensive side, that you know who to call and have a relationship with your CISA and FBI and HHS regional staff if you are sadly the victim of a crime, so we can restore quickly and get back to the business of saving lives. So there's a number of things we want to do, but we needed to put the quantification here in situ for as we approach the fifth wave. Subsequently, there's much to be studied and enhanced at the state level and county level so that we can drive more precise insights. These are just correlations, but they are incredibly strong. And we've already heard different academic and medical institutions looking to refine and enhance this analysis to have a much more precise prescription and remedy for what to do next. But to your policy point, we really want to make sure that we have proper right-sized proportional investment for cyber resilience as the nation increasingly depends on digital infrastructure to provide medical care. They increasingly depend on agencies like CISA and yourself to make sure that this dependence is dependable. Many of our system dynamics have revealed that even when COVID goes away, next proximal alternative care for things like strokes and heart attacks, where minutes and hours matter, need some resilience and possibly stimulus. We're going to have to make sure we have the capacity to absorb some level of failure regionally, and that we can prioritize response and probably offer the right kind of federal assistance to do our shared responsibility on the defensive half. So there's tactical and strategic goals here, none of which occur if we continue to believe that no patients have been harmed. That's the first sentence out of any hospital victim's mouths usually. I think it's time to shift from wondering if people got hurt to knowing it's possible. And this may galvanize political will across the federal and executive branch and state and local leaders that we do the right kind of things to shore up the promise of connected technology in healthcare while we mitigate the peril.
Thanks, Josh. Reuven, your last thoughts?
So I want to echo first everything that Josh has said in terms of the imperative and the fact that this is an issue that's a threat to life and limb, not just a threat to the bottom line, although that is a consideration. I think what I would want to see come out of this is, as I reflect on, as I have before, that this is a wave similar to the wave we had with quality. That there was a time when you just assumed that there would be a lapse in quality to a certain extent, and that with that, you prepare for that, accept that as part of the background of doing business. And then the realization that you don't accept that as part of the background of doing business. You have to optimize what you do to drive that to zero. I know the challenge of being told that there is now a new risk that has to have immediate attention and that has to be embedded into the fabric, but cybersecurity is that risk. The consequences are huge, and we simply can't accept the fact that cyber attacks are a cost of doing business. That poses a challenge for us. It poses a challenge for the clinicians. It poses a challenge for the hospital. But we have to come away from this knowing that it's an operational imperative for our patients, for our staff, and for the survival of the sector. And that we've risen to the challenge before. I'm confident we'll do it again, but we have to start from that premise that we need to find a solution that allows us to bring it in, and that a public-private vigorous discussion and jointly approaching this is going to be a critical part of that answer.
The urgency cannot be stressed enough. What we studied was the first 3 waves of the pandemic. Since this report was being tidied up and published, we have suffered a 4th wave of increased hospitalization, and we're on the cusp in December of the 5th and possibly most deadly wave of hospitalization. And as the sickness and death further hurts essential critical infrastructure workers, the country is watching in slow motion erosion to transportation workers, food supply, frontline first responders, firemen, longshoremen. We are starting to see cascading failures as we stumble to perform these national critical functions. We desperately need very strong data-backed decision support so we can mitigate the loss of life during this 5th wave. It's going to take hard decisions from every one of you, and we are willing and able to engage on stakeholder-specific conversations as decision makers in the private sector wrestle with these tough competing equities.
Thank you, Josh and Reuven, for your very candid and substantive discussion today on this very, very important issue. Obviously, totally agree that there is physical risk to patients, to critical infrastructure as a result of these foreign-based ransomware attacks. Again, as a sector, we are doing our part to defend and respond to these attacks, and we continue to implore the government to take offensive action against these adversaries who are being provided safe harbor in adversarial nations. And I also commend and congratulate the government on their recent enforcement activity, which has disrupted some of these ransomware gangs, including the arrests of individuals associated with the Reuven ransomware gang and the disruption of the Reuven network. Josh and Reuven, I also want to personally and professionally thank both of you for coming back to government. You had a nice life in private sector, and with taking on additional personal and I'm sure financial sacrifice, you came back, you came to the government to serve, to help defend the nation during a crisis. Very, very commendable. And I also want to thank all the men and women of CISA for what they do to advance and defend healthcare and keep the nation safe. And of course, thanks to all our healthcare listeners for what you do every day and have done during the pandemic to care for our patients and keep our communities healthy. This has been John Riggi, your Senior Advisor for Cybersecurity and Risk. Stay safe, everyone.